Thank you so much for having me. I am really honored and delighted to be here. I rarely get the chance to talk about this topic with fellow internists, so this really makes me incredibly happy. Um, so thank you for being here today. I have nothing to disclose, and I will use women and mother to mean female parent, but I know that not all of such people identify as women or mothers. So today I'm going to talk about why breastfeeding matters for adult patients and for population health. I'm going to go over the physiology of breastfeeding and lactation and how you can support your breastfeeding patients. And to that end, I'm going to talk a bit about medications and about caring for hospitalized breastfeeding patients. And I'm going to say some words about managing mastitis. So the current recommendations for breastfeeding is for women to exclusively breastfeed for the first 6 months of life. And what that means is no other food or drink besides breast milk. That means not even water, because water isn't actually necessary. And then after 6 months, there should be continued breastfeeding for at least the first 2 years of life, and with the addition of complementary foods. And these are international recommendations, pretty much all countries in the world that have recommendations. And the World Health Organization recommends this, and even the American Academy of Pediatrics now recommends at least 2 years of breastfeeding. Breastfeeding has a very significant impact on maternal disease. A lot of people don't recognize or realize this. And so the more lifetime breastfeeding experience a woman has, the lower her risk of many maternal diseases. Breast cancer, ovarian cancer, endometrial cancer, hypertension, MI, type 2 diabetes, and stroke. So, and if she weans her baby early, her risk of these diseases goes up. So every child she breastfeeds, she gets more months of cumulative lifeline lactation and gets a lower risk of these diseases. And when you think about it, how many health behaviors do we have that has this kind of broad impact on diseases? And this is just in mothers. There are very few things we have that has this kind of impact. It's really tremendous. And so if we can just even focus on this one behavior and trying to support it, we can do a lot for population health. You're probably aware that breastfeeding impacts child health, ear infections, diarrhea, lower respiratory tract infections, and a lot of this is more pronounced with exclusive breastfeeding. But it also impacts some chronic conditions like autism spectrum disorder, childhood leukemia, and sudden infant death syndrome. There's also an impact on childhood obesity. One underappreciated impact of breastfeeding is on intelligence, cognitive effects. Breastfeeding will give about 6 extra IQ points to a child. And this is irrespective of a mother's background or education. The mechanism's unclear. An infant's brain grows very fast. It about doubles in size in the first year of life. And the breast milk does help with myelination of the neurons. So that probably has something to do with it, but it also may have to do with the interaction of the mother and child during the breastfeeding process. That may have something to do also with the cognitive effects. So the 6 IQ points turns out to significantly affect a child's earning power, and it translates into about $100 billion a year in the US and over $300 billion a year globally. So that's $1 billion a day, almost. And so this is really significant. I'm going to go talk a bit about basic lactation physiology. So infants need to eat about 8 to 12 times a day, at least for the first several months. And that's every 2 to 3 hours on average. And this is because of the low fat and protein content in breast milk. It's digested very easily, and infants are also growing at an incredibly rapid rate in their first year of life. Their brains double in size, their bodies grow very fast, so they just need to be eating all the time. And milk is produced by supply and demand. So the more often an infant breastfeeds, the more milk their mother will make. And if a mother skips a feed, that means she'll be making less milk. If she substitutes a feed with formula, she'll also make less milk. Now, pumping with a breast pump, it by and large will drain less milk from the breast than a nursing baby. And so it may result in less milk production. And this can be significant when a mother returns to work. Her milk production may drop. For some women, this is important because some women are what we call exact producers. They only make as much as their baby consumes and no more. And so they end up really struggling when they return to work. And what sometimes happens when moms return to work is infants do what's called reverse cycle feeding, and they start breastfeeding a lot during the night to make up for mom's absence. This takes some of the pressure off of pumping, but they do start breastfeeding at night and eating less in the day. So breastfeeding every 2 to 3 hours, 24/7 for months and months and months. How in the heck do women do this? Yes, it's a lot, right? But somehow the human species has done this for many millennia. And how have we done this? Well, one way we've done this is by basically wearing babies on our bodies. So they're kept with us all the time, and so they're easy to feed just whenever a baby is hungry. There are societies where babies' feet literally don't even touch the ground until they're walking. And babies are generally happier when they're worn on their mother's bodies. They rarely cry, and they like to be in physical contact with their mothers. There are societies where strollers are not even a thing, they're not heard of. And so you really have to be next to the baby to feed them this often, and that includes at night too. So it's normal human physiology to sleep next to the baby and have the baby feed at night. Now, one reason that I do a lot of research on bed sharing and SIDS is because a lot of women give up breastfeeding because they can't manage to feed their infant every 2 to 3 hours through the night. They just get exhausted. But the way the human species has survived is by doing what's known as breast sleeping, sleeping on your side and nursing the baby through the night. And when women do this, it's not exhausting. They don't wake up. They're not getting up at night changing diapers. They're just basically switching from their top breast to the bottom breast and nursing all night long. When they get up in the morning, they have no idea how many times they've fed the baby, and they wake up pretty refreshed. It's not exhausting to actually feed your baby this way. And if a mom goes back to work and the baby's reverse cycle feeding, this is actually not all that exhausting. And so this is how moms get by. This is how the human species has managed to survive all these millennia. So moms who bed share breastfeed more often and for more minutes, and this has been shown in a sleep lab. They breastfeed about twice as often as solitary sleepers and 3 times as many minutes per night as solitary sleepers. And as you saw from the basic physiology, this means that they're going to be having a lot more robust milk production than solitary sleepers. So it's not surprising that bed sharing promotes breastfeeding duration. If you look at these Kaplan-Meier curves, you see that the bed sharers end up, people who bed share more breastfeed longer and breastfeed exclusively longer for more months and more weeks. And this has been shown over and over. Dr. Crow and I just published a study that came out just this week about bed sharing doctors. They breastfed 4 months longer than doctors who don't bed share. And that's a lot when you think about what that translates into in terms of maternal disease. It's a lot. Unfortunately, the American Academy of Pediatrics has long discouraged bed sharing. They are concerned about an increased risk of SIDS with bed sharing, and they discourage bed sharing in all circumstances, even for breastfeeding mothers. But we know that women who don't bed share don't breastfeed as long. So it's this conundrum. What do you do? The AAP doesn't distinguish between bottle feeding mothers and breastfeeding mothers. And bottle feeding mothers sleep entirely differently than bed sharing mothers. And they sleep in ways that are actually quite hazardous and can cause suffocation risks. And breastfeeding mothers sleep in ways that are actually protective for the infant. Other countries are starting to recommend safe bed sharing and are not taking the same stance as the AAP. So things are starting to change. But what the evidence shows is that bed sharing really is of concern just in certain circumstances. And in these circumstances, bed sharing has a higher risk of death. And that's sharing a sofa. So sleeping on a sofa with your infant is very, very hazardous. It's hazardous if parents are smokers. It's hazardous if the parents have consumed alcohol and get in bed with the baby. And it's hazardous if it's a preterm or low birth weight baby. So if any of these things apply to a parent, then it's good to have the baby not in the bed, but near the bed. So a solution would be to have one of these co-sleeping baskets attached to the side of the bed. And that would be a safer solution. And then the infant is still within arm's reach. The Academy of Breastfeeding Medicine has parent handouts and clinical protocols on how to bed share safely that you can give to parents, and physiologic infant care, which is all the stuff I've been talking about, normal physiology and how to cope with the need for frequent feeding and not end up exhausted. And so these are resources that you can use. And I was an author on both of these things. One thing that the AAP messaging does not really get out there is they just say don't bed share, but people don't associate sofa sharing with the word bed sharing. And so unfortunately, a lot of people don't realize that this is not safe. And people have even gone to sleep on a sofa with their infant in an effort to actually avoid bed sharing. They've even fallen asleep on the sofa by accident, trying to not share a bed with their baby. So it's really a public health messaging failure. Okay, on to more physiology. So believe it or not, infants don't suck milk out of the breast. Milk is sort of pushed out of the breast. What happens during a breastfeed is the infant will latch on to the nipple in a very specific way, in a very specific position that, if it's done correctly, is not painful. And what they'll do is the infant will take a series of short little sucks, and those short sucks will cause oxytocin to be released from the mother's pituitary gland. Oxytocin will go down to the milk lobules, which are these big pink things in the picture. Inside the milk lobules are alveoli full of milk. And surrounding the milk globules are muscles. So the oxytocin will cause the muscles around the milk globules to contract. the milk will get squeezed down through the ducts into the lactiferous sinuses, which are these widened ductal areas that lie right under the areola. And then the infant will see this the milk down there and will use peristaltic motions of their tongue to milk the milk out of the lactiferous sinuses into their mouth, and then using a sort of complicated coordination between sucking, breathing, and swallowing, they will drink the milk and it will end up in their stomach. So it's all a very complicated dance between hormones and muscles and peristalsis. Is very, very different from bottle feeding. Several of these oxytocin bursts will happen each breastfeed. The other super amazing thing about breastfeeding is that breast milk is dynamic. Milk changes in the course of a feed with each breast. So the milk at the beginning of a feed is watery, which helps meet the infant's thirst needs and hydration needs. And milk toward the end of the feed becomes more creamy, which helps meet their hunger needs. The other thing is the nutritional characteristics change with the infant's age. So a mom will make about the same amount of milk per day throughout an infant's age. So the mom of a 1-month-old will make about 800 cc's a day, and so will the mom of a 6-month-old. But the nutritional content will just get more dense as the infant gets older. The other cool thing is that the milk's immune properties adjust with the mom and the infant's exposure to pathogens. So if the infant is exposed to a pathogen, something we think in the infant's saliva will signal through the mom's breast to her body. So she makes specific antibodies that go in her milk and help protect the infant. And then if the mom is exposed to a pathogen, she will make antibodies that go into the milk and help protect the infant. Breastfeeding is way more than just the milk. It's very different than human milk feeding. It is a complex social, behavioral, and physical relationship. And you see in the picture, the baby is gazing up into the mother's eyes. The mother is gazing into the infant's eyes. A newborn baby's gaze is set to be pretty much the exact distance to the mother's face and can see little else besides their mother's face. The behavior at nighttime for a breastfeeding dyad is very different from anything else. There's a whole lot of interactions that happen in the breastfeeding process between the mother and the infant. They learn how to breathe, they learn how to move their neck differently. Everything is very different than a bottle feeding infant. Pumped milk has fundamentally different qualities than milk from direct breastfeeding. And then this antibody production really depends on direct contact between the infant's mouth and the mother's breast. Okay, so I'm going to talk a bit about medications because this is one thing that's going to come up for you a lot. If your patient has young children, 2, 3, 4 years old, please ask if they are breastfeeding. Don't assume that they're not. And then if you want to prescribe a medication and you're not sure if it's safe, take a moment to look it up. It wasn't that long ago that I frequently see that people would just say, well, I don't know, they just routinely tell moms to pump and dump their milk because they couldn't be bothered to look it up and they thought it didn't matter. But it really, really matters. Interrupting lactation, even for a few days, let alone a week, can really harm the breastfeeding process and can often result in the mom unintentionally weaning her child when she really doesn't want to. And it can affect the infant's health. Just a few bottles of formula can change the infant's entire microbiome. So you really don't want to do that. The good news is there are a couple of free resources that have great evidence-based information on how to on medication safety in breastfeeding. One is LactMed from the National Library of Medicine. It's online. There used to be an app for on your phone that's not there anymore, but yeah, it's online. And the other is eLactancia from Spain. There's an English version that will probably just automatically pop up for you if you type in eLactancia. Um, the Infant Risk Center at Texas Tech has great information as well, but doesn't have a database. If a med has not been studied, there's still some general principles you can use to guess whether it's safe. So what happens when a breastfeeding mom takes a medication is that the medication may pass into the milk and then it will pass out of the milk compartment once it gets metabolized. So smaller meds, smaller molecules will pass into the milk, but larger ones generally will not. Anything that's highly protein bound is probably not going to pass into the milk. So if you see like a big monoclonal antibody, that's not going to go into the milk. You have to be careful if the infant is preterm, so you should ask your patient if their infant is preterm because their livers and kidneys won't be able to metabolize a drug very well. For an infant to be able to absorb the drug, it has to be orally bioavailable. So if you're giving something like gentamicin that's not going to be orally bioavailable, you're not going to matter. If they swallow it, it won't matter. Some meds might be safe for the baby, but they can impair milk production. The two big ones are pseudoephedrine and aripiprazole, Abilify. So pseudoephedrine, we even use therapeutically if we want to cut mom's milk production for any reason, like hyperlactation. But that one is well known to drop mom's milk supply. If you want to give a drug and you look it up and you find there's no data, you sometimes have to be creative. I would say you should consider an alternative that's known to be safe or safer. And the alternative shouldn't just be, well, tell the mom not to breastfeed, because not breastfeeding also has significant health risks, and you have to put it in that context. So I would think about using a different drug or even a different class of drugs, for example, like a different type of antibiotic, for example, that kind of thing. And I want to put a plug in for shared decision making. I can't tell you how much breastfeeding really matters to a lot of women, not just for her health, but a lot of women just are really committed to breastfeeding. It's very, very important to them. And they should be part of the decision. So she should be able to choose if she wants an alternative drug that might be less effective, if she wants to even forgo treatment and see how she does without the drug. She might want to be willing to take the drug, but also be willing to have her infant monitored with blood tests or whatever else is required. She may be willing to take the drug and be willing to have her milk sent off for study to Texas Tech or something, or have her infant samples, blood tests or whatever, sent off for study. So try to make that decision with her and give her that chance. I'm going to talk about a few selected meds that we hear about a lot. So the biggest thing I tend to hear about is IV contrast and MRI contrast, because all the time we hear that a woman goes for a CT scan or MRI and someone in X-ray told them to pump and dump their milk for the next day or two. And that is just not indicated. The American College of Radiology has a statement that these agents are safe in breastfeeding women, but a lot of times people in X-ray, even some radiologists, don't know this. If you're ordering one of these tests for your patients, I would advise you to tell them beforehand that it's safe to breastfeed, because chances are someone will tell them it's not. Local anesthetics are safe, but it's not uncommon for me to hear stories of women whose dentist told them to pump and dump after they had a tooth pulled or something. Um, General anesthesia is safe once the mom is awake and alert, because that means the drug has left their brain compartment, so it's also left their milk compartment. Um, we know that we don't use ACE inhibitors and ARBs in pregnancy because of the risk to the developing kidney, but they are safe in breastfeeding, at least the ones that have been studied. Our anesthesia colleagues have this nice graphic. Unfortunately, they used a baby bottle for some reason that summarizes safety of a lot of anesthesia agents in breastfeeding. The big one to avoid is meperidine, which they sometimes give for shivering post-op, and that should be avoided because it has a toxic metabolite. They recommend monitoring closely if morphine or hydromorphone has been used. You can easily find this graphic online if you Google it. Okay, I just want to spend a few minutes on cardiomyopathy because peripartum cardiomyopathy is something we do see. And the good news is that just this year, the folks at Texas Tech published a paper on Entresto, which is now found to be safe in breastfeeding because very little of it gets into milk. Some ACE inhibitors and ARBs have been studied and are safe. Spironolactone is safe. If you do a lot of vigorous diuresis with loop diuretics, that could impair lactation. Carvedilol is safe, but metoprolol has more data, so this might be a shared decision-making kind of thing with your patient. If you want to use an SGLT2 inhibitor, the manufacturer says there's a theoretical risk to the developing kidney. So this might be a shared decision-making kind of situation where the mom might or might not want to go on this drug or might want to take the risk. It's really something I would discuss with the mom. If you are going to use one, I would go with Farxiga because it is more protein bound. There's good news on hydroxyurea, which we use for sickle cell disease, that it is safe and only excreted in small amounts, but to minimize the amount exposed to the infant, it's recommended not to take it until 3 hours after a breastfeeding session, if possible. So this can help, millions of women around the world. For social substances, for alcohol, it's recommended to wait at least 2.5 hours after a drink. Alcohol is a very small molecule. It gets into the milk compartment. Tobacco can decrease milk production, and obviously you shouldn't smoke around an infant, and you should support women to stop breastfeeding. Cannabis is something you should ask women about because a lot of people think because it's legal, it's safe, but it really can impair milk production and impact brain development. And if a mom is on medical cannabis, you should try to switch them to something safer for the same problem. Methadone and buprenorphine are safe. Okay, for hospitalized moms, the key is to try to keep the mother and infant together when possible. And to do this, it's best to have a policy on the med-surg unit if one doesn't exist. And that policy should really focus on allowing the mom to have a guest to be in charge of the baby 24/7. So staff should not be in charge of the baby. They shouldn't be handling the baby. And the policy should include provisions for a safe place for the baby to sleep because a hospital bed is not really set up for a baby, and where to store the mom's milk. And it's going to be easier for a sick mom to directly breastfeed their baby than to be fiddling with a breast pump. But it should be good to have some pump milk on hand in case the mom has to go for a test or a procedure. And, the longer the mom is separated from their baby, the higher the risk that she'll end up weaning the baby unintentionally. So the sooner she could go home, the better. The more she could be with her baby, the better. The other things to consider is that the mom does have this 800 cc's of milk she's making. So if she's NPO, you have to crank her fluids up accordingly. A lot of times we'll hear staff saying, I don't want a baby on the floor. What about the guy with C. diff down the hall? But that's not really a concern. Okay, now for mastitis. You may see women with mastitis. And we're now starting to think that mastitis is really an inflammatory condition more so than an infection. So we'll treat it more like a sprained ankle. And that's with sprained ankles, you treat it with rest, ice, compression, and elevation. So that's how we should think about mastitis. So rest means no pumping, no massage, no squeezing of the breast. You could still breastfeed, but nothing extra on that. Icing it and wearing a supportive bra that adds a little compression and elevation. So what happens in mastitis is that there's a lot of edema that builds up. You can see in this picture here. And the edema causes the ducts, which are these very thin hair-like structures, to get narrow. And that causes the milk to back up into the alveoli and the lobules and swell. So there's just a lot of swelling. And ice and compression and elevation will help that go down and restore the normal structures here and allow the milk to drain. But if you have a persistent fever in the woman, that requires some evaluation, and they may need antibiotics. They may be developing an abscess that requires drainage. The lead author of the mastitis protocol from ABM is a breast surgeon. She says she gives antibiotics maybe 2 or 3 times a year. A lot of women will say they have a clogged duct, as they feel a lump in their breast and they say that's a clog, but their ducts don't store milk. So there's no such thing as a clogged duct. The lump they're feeling are these alveoli that are full of milk because the ducts are narrow. You see how narrow they are here, and this is like comparatively a normal duct size. So squeezing and massage will just cause more inflammation and make it worse. So what you really just have to do is ice it and try to get this edema down, and antibiotics won't make it better. Sometimes we use ultrasound things, but really ice should really help the problem a lot. We have resources on mastitis. We have a clinical protocol, and we have this parent handout. So my takeaways are that breastfeeding is really important for adult health, and it's really important for population health. But breastfeeding is, can be challenging for people. So please support your breastfeeding patients, make the extra effort, and support your breastfeeding colleagues and your breastfeeding residents. And thank you again for having me, and I'm happy to take questions.
Well, thank you so much, Dr. Bartick. That was a wonderful presentation. You touched on basically every specialty in internal medicine, which I think is why it was so important to have an internist come and speak to this group. And I know that was more lactation education than I think I've received in all of my training so far. So thank you again so much for bringing this important topic to us. I just briefly wanted to acknowledge that, for some people, breastfeeding or lactating at all is either not a choice, or in their shared decision making with their families or their healthcare providers, they've elected to formula feed instead. This can be a hot button topic for a lot of people. And so I just want to acknowledge that, although sometimes, these things can be personally triggering from a personal experience perspective, I think from a perspective of physicians, it's vital for us to know these data and to really understand that the health benefits for the infant and for the lactating parent are there, and they're very crucial to understand so that we can counsel our own patients appropriately and really understand the science. So thank you again. We do have some questions. So first question, is it true that the worldwide average years breastfeeding is 9 years, or do you have any information on the duration of breastfeeding worldwide?
It's not 9 years. I I think it's somewhere between 2 and 4 years. It's not 9 years.
Mhm. Okay. 2 and 4 is still longer than many people think of for nursing relationships. Um,
Yeah.
yeah,
Yeah, and
definitely.
to your earlier comment, I just want to say, we have to separate our own personal experience from medical recommendations and the data. And we also have to recognize that every mom and every family is doing the best they can with the resources they have. And, people make their own choices for whatever reasons that they have. So, that's how I think about it.
Absolutely.
Okay.
Thank you. Okay, another question. So, does maternal breastfeeding associate with beneficial outcomes in paternal health, similar to those of maternal health? And if so, how would you establish a causal relationship?
Hmm. I don't know of any. I don't know of that. I know that that uh, paid paternity leave is associated with longer duration of breastfeeding. I know that certain things help dads feel better, like skin to skin contact with the dad helps with bonding and things like that. So all of that is good, but I don't know about those other things, and I can't answer more to that. I'd have to
Thank
think more
you.
about study design that I couldn't answer in the course of this lecture.
Mm, yeah, absolutely. I could imagine that bed sharing for the mother might interrupt the dad's sleep a little bit less. That could be a potential mechanism, but okay, thanks. And then as far as the effects of breast sleeping on infant dental health, are you aware of any information about dental health and babies who nurse throughout the night?
Um, so the last I knew about this is that there was mixed data about this. I think if a baby, if a baby fell asleep with milk in their mouth, there was some increase in caries, but I don't think bed sharing is associated with increased caries risk. So um, I don't think that that's a significant risk.
Thank
Um,
you. And next is in terms of the many benefits to mom and infant, how thoroughly are these benefits adjusted for the wealth of the mom? Is there, if longer breastfeeding may be associated with maternal socioeconomic class and education, um, is there an adjustment for wealth and socioeconomic status as far as these benefits are concerned?
um, So I think these studies that show these are, big meta-analyses that I have to go back and look, but I think this sort of thing is controlled for. Um, so I think this is actually um, a true effect of breastfeeding. For example, I didn't cite it here, but one of the earlier breast cancer studies was done in nuns. and showed that uh, um, uh, nuns had higher breast cancer rates. And there have been other studies where people who only breastfed from one breast had higher breast cancer rates on the side that didn't breastfeed. So that's the ultimate control there.
Interesting. Thank you. In terms of mastitis treatment, do NSAIDs help?
Yes, they do help. Mhm.
Excellent. But in general, we're not recommending empiric antibiotics. Is that correct?
No, not unless they're not better or the fever persists.
Great,
And
thank
then
you.
you want to cover like staph. And you can also culture the milk. So I recommend a milk culture before you start them on antibiotics.
Excellent. Thank you. Okay, and we have a comment. Thank you for this important work. What advice do you have for ensuring we're adequately supporting trainees who are breastfeeding and also working long hours?
That is hard. I would make sure that they allow them their time to pump, make sure they get out on time, and yeah, when I've had trainees that have had babies, I make sure that they're able to peel off and pump, and take whatever time they need to take, and make sure that I'm supporting them with that and thinking of them. Um, if they need, if you're in an administrative position and you can make sure that they take as long a maternity leave as they're allowed, that would also be good. So those kind of things. They're little things. There may not be a whole lot you can do. Also, if you're in an administrative position, to make sure that there's a pumping space that's convenient for them and they don't have to go really far away to pump and express their milk. A lot of women use these wearable pumps, so they can even like be rounding while they're pumping. Some people do that, but those are the kind of things that I would do. I just try to be supportive and show them that you're supportive, and not make them miss stuff if they need to pump.
Absolutely. It's a great challenge we've been trying to address here at Stanford with the Lactation Council. The Federal Pump Act has also recently, become law where time and space to pump is actually federally protected, which is amazing. And I encourage any of the Department of Medicine trainees or faculty to reach out to me or to the WellMD Lactation Council for any concerns specifically at Stanford with helping our trainees or faculty um, be able to pump at work. So how closely is breast milk production associated with maternal stress?
Well, so that's a great question. So maternal stress can affect the letdown reflex. So if you're very stressed, the oxytocin is not going to come out and you won't let down. And the other thing about stress is it depends on the type of stress. If you're missing feedings because of stress, then you're not going to make less milk. But I think it primarily can affect the oxytocin. I remember once I had a patient when I was breastfeeding, and I had a patient with necrotizing fasciitis, and I kept trying to pump during the day. I was trying to transfer this patient to a tertiary care facility, and my milk just wouldn't let down all day because I couldn't find a hospital to take him. And then when I finally found a hospital, I was finally my milk let down. But it was an interesting convergence of breastfeeding and medicine right there.
Interesting, interesting. I think many have similar examples who have attempted.
Yeah.
And there was a follow-up comment to that, when trying to pump at work while typing, sometimes this commenter is seeing reduced volumes, perhaps related to fewer oxytocin bursts is the theory. Do we believe that stress hormones are inhibiting oxytocin to be able to create the letdown reflex in these cases?
Yeah, they may be. It may be. I mean, it may be. Some people will help the oxytocin reflex by bringing something that smells like their baby or having a picture of their baby that can help the oxytocin reflex for some women.
Really interesting. And I'd like to emphasize too, in commenting about the Federal Pump Act, that you are permitted to work during your protected lactation time. However, you are not required to work during that time. And so the understanding is that if you have a break for lactation during work, that you can absolutely take that time off of Epic and not be typing. Of course, practically that's a little bit more difficult of an ask, but from the legal perspective, you actually are allowed to do whatever works best for you to express milk at work. Okay, I believe that's the end of the Q&A. Happy to have any other questions come through, or if not, um, again, thank you so much for bringing this important topic to medicine grand rounds. So important, and you've done really amazing work in this space, and we just really appreciate you joining us today.
Thank you so much for having me. I'm really happy to be here.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.